Welcome to another episode of Doctor, the award-winning radio show and podcast featuring your physician host, Dr. Tom McGovern.
And Dr. Chris Stroud. And this is the show where we and our guests will discuss relevant health-related topics and always from an authentically Catholic perspective. Now, Doctor is brought to you in part by the generous underwriting of our friends at CMF Curo. You can learn more at mycatholichealthcare.org. Live your Catholic faith in your healthcare with CMF Curo.
Today, our guest will be joining us across the EWTN Global Catholic Radio Network. Joining us will be Dr. Barbara Golder, physician and lawyer, to talk about the malpractice system in the United States from the perspective of both a physician and a patient. Chris, why is this topic important for our listeners?
Well, I mean, there's probably a lot of good reasons. When you say that, the thing that comes to mind is that we are all at one time or another patients. Let's just face it, right?
Yes.
And that means we are all going to intersect with physicians and other healthcare providers of some flavor. Professional liability or malpractice, and we can talk about what those words mean as we get into this, and all that goes with it, whether that's defensive medicine by its phrase, or cost of medicine, or anxiety, or frustrating rules, all of those things affect every medical specialty across the board. So that means this topic is absolutely unavoidable. If you're a patient, you're going to interact with a healthcare provider, and there is no way to be a healthcare provider or a patient and not be touched by this topic. I think when it's all said and done, after talking with our expert guests, we're going to come away with a sense that most professional liability cases, or so-called malpractice cases, really come down to poor communication. And maybe, just maybe, that's a big life lesson for us. I mean, think of how many problems are seemingly inherent to the human condition that we could maybe solve, or at least make better, with more effective communication between people.
And we learned so much of that in medical school, didn't we, Chris?
And we're rewarded for it so handsomely as well.
Yes.
Yeah, physicians of all varieties, we make mistakes. Healthcare providers make mistakes. We are human. That's not really at debate here. But the discussion should leave us, I hope, with a sense that we've got some responsibility as patients to fully understand everything that's being done to us and that's being said to us. If we don't understand it, it's incumbent upon us to make the provider make us understand it. So, Tom,
yes.
This crazy topic was your idea, I think. So what in the world made you want to talk about professional liability and malpractice on a show?
Well, it's just so much fun, Chris.
Absolutely.
I was subpoenaed to be an expert witness in a case early in January, thinking, wow, what a big deal. And then I realized you've done this many more times than I have. But in prepping for this, I had to go through just about 1,000 pages of depositions. I then had to go into court, and I was only in there on the stand for like 3.5 hours. My fellow expert who was on the day before was on for 7 hours. And it was a really bizarre process in the courtroom where I felt like the plaintiff's attorney was just on a fishing expedition to try to find something, anything that would stick. And so I tried to make the best of it. I got the jury to laugh once. I got the plaintiff's attorney to laugh once, but I didn't get to use a great analogy. There was someone in the room from a malpractice company, insurance company, and they said, "Oh, what do you plan to say when they ask about your qualifications?" And I said, "Well, during the pandemic, I read 70 Perry Mason novels about how courtroom etiquette works." And she thought that would just be outstanding if I had a chance to say that, but I didn't. So I am here. But I realized, yeah, I know. But I realized that so many people think it's a black box. We don't understand it. And I've been involved in a number of cases. You've been involved in even more cases. And now to have a lawyer on, we thought maybe we could peel back the curtain for some of our listeners.
Because, one of the strange things, I guess, for lack of a better phrase, about the law is, of course, they have words that everybody doesn't use. We do that in medicine too.
Yes.
But lawyers are trained to think in a different way than most of us think as we're walking down the street. So that can make communication between us civilians and attorneys sometimes very complicating. And it'll be fun, I think, to talk to our guest about how do you learn that method of communication and how do you use it more effectively?
So, what are some of your best memories from malpractice cases that you've been involved with?
Well, let me think. I have absolutely none. Um, yeah, I can't think of any good memories.
That's
No,
why I said best.
it's pretty funny. I was an expert witness once. I've done that several times, as you mentioned. It's part and parcel of being an obstetrician. I've actually done it on both sides, for the plaintiff or a patient who might be
Right.
bringing a case, or I've worked for the physician or the defendant who might have had a case, brought against them. And I have to say that it's made me better. It's made me a better physician. It certainly made me a better listener. And while it's not funny, I have to say one of the things that sticks into my head as the most bizarre is I was an expert in a case and I was going on and on with all of my expert testimony that I thought made me sound really pretty brilliant. Um, and I glanced over at the jury and every one of them were asleep. And I
Oh
thought, well,
no.
maybe my testimony is not quite as titillating as I thought it was.
Oh no. Well, they're just sitting there. In the case of mine, they were sitting there for 3.5 days and sometimes till 7 or 8 at night.
Yeah,
I can't imagine.
right. It's hard.
So, interestingly enough, almost 60% of physicians have been sued at least once, and a quarter more than once. And of course,
Mm.
procedural specialties like we have are sued more. Number one was not your specialty.
I
Your
know I was pleased
specialty,
to see that.
yeah, it was only 83%, whereas 85% of general surgeons, 84% of urologists. In our own state of Indiana, turned out to be number five, with 70% of docs sued at least once. Kentucky, number one at 75, and not surprisingly, gambling-rich Nevada at number two at
Oh,
73%.
wow.
So, so should we tell our listeners where we fall with regard to this?
Well, I'll tell you, in the interest of transparency, I've been sued several times as an OBGYN. And I would say every one of those times, it's exactly what I mentioned at the beginning. Poor communication, usually poor communication on my part, where something was confusing. But it comes with the territory, unfortunately. Now, fortunately, all of the cases against me have been dropped. That is, they haven't gone on to the real Hollywood trial or a
Right.
settlement. But especially in high risk specialties like ours, where you're doing procedures, I really think it's important for listeners to remember and for us to remind ourselves that the allegation of malpractice doesn't mean malpractice occurred. And that sounds defensive, but it is the truth. And even for that matter, a finding against a healthcare provider by a jury doesn't necessarily mean the provider actually did something that's wrong. It's a complex and a complicated system. I think our guests will help us navigate those concepts. But I think as we think about it, it's really important to keep those principles in mind.
And I think that's a great way to segue into our interview. But first, we have our medical trivia question of the day. And this was a fascinating thing I found. The category physician responsibility to patients. The concept that every person who enters into a learned profession undertakes to bring to the exercise a reasonable degree of care and skill dates back thousands of years. In fact, in the oldest such document, it says exactly this. If the doctor has treated a gentleman with a lancet of bronze and has caused the gentleman to die, or has opened an abscess of the eye for a gentleman with a bronze lancet and has caused the loss of the gentleman's eye, one shall cut off his hands. Wow.
That's that's tough.
So the question, was this ancient document written and discovered in which of these five countries? A, England, B, Iran, C, Italy, D, China, or E, Greece? And for bonus points, name the document. But we'll be back with the answer to that at the end of the show. But before that, and after the break, Barbara Golder, our expert physician and lawyer, here on Dr. Doctor. Welcome back to Dr. Doctor, where we have our guest today, Dr. Barbara Golder, MD, JD, who's going to talk about the malpractice system with us. Barbara's trained as both a pathologist, a lawyer, and an ethicist. She splits her time between Tennessee and Colorado, although during this interview. She's actually in Florida. She writes murder mysteries, the Lady Doc Mystery Series, which I have read all of the current ones out there, and they're wonderful. And she's the editor of the Lineker Quarterly, the official medical journal of the Catholic Medical Association. Barbara, welcome back to Dr. Doctor.
Thank you. It's always good to be here. I appreciate your asking me on.
Now,
Well,
Barbara, it may sound like a silly question, but explain to listeners this JD business. Most of them know MD or DO, and in medicine, we love our alphabet soup after our names, but help us understand this JD thing.
JD means Juris Doctor. It was LLB, Bachelor of Laws, because it was just done differently. At some point in time, they decided that was not appropriate, and they changed over to JD. And anybody who had an LLB could upgrade, could change it, but it just means Doctor of Laws. So it's a lawyer degree instead of a medical degree.
Excellent.
and what does Esquire, ESQ, mean after some lawyers' names?
That's just another lawyerly designation. Esquire it designates that you're an advocate, a lawyer.
Okay, well, let's advocate for the truth tonight with us, Barbara.
So, Barbara, right off the bat, the terminology, in medicine, as I said, we love our terms. Malpractice, mal means bad practice. We say professional liability. We've got all kinds of words to describe these things. But what do you mean malpractice? And how's that different from, he's a good guy, just made a mistake?
Well, it has a fairly specific definition in law. Malpractice means, first of all, that you had a duty to the patient. You were in a doctor-patient relationship. You had a responsibility to treat the patient and treat them properly. The second is that you breached the standard of care, whatever the standard of care happens to be. In other words, whatever you did was not appropriate by the standard of the community. And we can talk about that more later. And that breach caused injury to the patient, so that the patient was in fact injured by the breach. Whatever you did wrong hurt the patient in some particular way.
Now, of those items, what do you think is the most contentious? What's going to be the hardest to sort of decide of those?
Well, it sort of depends on the case, and I don't mean that as a wiggle room lawyer answer. I really don't. But sometimes it's the injury. Sometimes you can do something wrong, and the patient's injury is fairly minor. And so sometimes the contention is how much injury is there. But often the question is, did you breach the standard of care? Is what you did wrong, and by whose standard?
So in the beginning one was the duty. And I've even seen cases where it's questioned whether there was a duty established. What does that mean?
That's right. Well, usually it revolves down to, were you in a relationship with the patient that made an obligation on you to take care of them in a particular way? Sometimes the doctor-patient relationship isn't really there. Most of the time in malpractice cases, that's a given because it's a long-established relationship. It's, a surgeon or an internist or something like that that's taking care of the patient for years. But sometimes the question is, do you really have a duty to that patient? Had you established a relationship? And that, again, is a question of very particular points of the law, which is something people don't always understand. What sounds like common sense to the world may not be sensible at all in law, and vice versa.
Well, my grandfather, an old farmer, used to always say, common sense is anything but. Now, you mentioned this term earlier, standard of care. It gets thrown around a great deal, especially in my specialty of obstetrics and gynecology. But help listeners understand, what is this phrase, standard of care? What is it, and what is it not?
Well, in some ways, it's a phrase of art, which means it's not terribly well defined. And in some ways, it's actually very well defined in law. And most of the time, you kind of live in another world between those two things. The standard of care, simply put, means what the physician is expected to do for the patient in a particular way. For example, it would probably not be the standard of care to bleed a patient with leeches today. Okay.
But if we use little sharp metal lancets, that would be okay, right?
That might be okay. But in 1500, that was the common treatment for things. So in some ways, it's what's in common usage. In some circumstances, it's what's been established by professional groups like ACOG, the
Sure.
Association of, what is it, the American College of Obstetrics and Gynecology. In some ways, it's established by law. And so it really depends, again, on the facts of the situation. But there are a lot of things that go into saying there's a there's a range of things physicians may do to care for patients, but it is a range, and there are some things that are outside the range. And the things that
So
Now,
are out,
in
now I know
saying
that.
that, no, I was just going to say, you can't go to standardofcare.com and
Right.
look up, what's the standard of care for taking a cancer off the end of someone's nose like Tom does. And so this is a challenge, isn't it? Because it isn't always, as you mentioned, it isn't always really clear what the standard of care is.
exactly. And the standard of care for Tom, who is in one particular field, might be different than the standard of care for my husband, who treats patients with similar conditions with radiation. So
Nation.
the standard will vary according to the physician, the patient's condition, the patient's desires, because the patient has a role in saying what he wants, and the patient and the physician's specialty. But I like the standardofcare.com. I might go buy that
You can establish that.
website. Yeah.
Yeah, buy that one. So Barbara,
Actually,
something I'd like to say something that ACOG, American Academy of Dermatology, every time I see something that put out in education, it says specifically, this does not establish a standard of care. Have you noticed that in your specialty, Chris?
oh, sure. Everyone is afraid, and rightfully so. They aren't trying to say this is what you have to do, and there's no way to do anything besides this and still be right. So I think they're appropriately fearful that what they're saying is going to be taken as an absolute.
So what do you
Right.
think of
And
that, Barbara?
what I think that's wise on their part, because exactly what you're saying, Chris, they are afraid that it will be taken as an absolute. And those things are rarely absolutes. There are a few, but there are relatively few. And that does not, however, mean that they can't be put in evidence as to what the standard of care really is. Now, when
Hmm.
you get right down to it, the standard of care is what the court decides in any particular case is the standard of care, which makes it so tricky because a physician can work very confidently and very competently to take care of a patient according to what's known
Hmm.
and his practice and what's in the community and all those things. And a court can, in fact, come along and say, that wasn't enough.
Hmm.
Now, that physicians worry about that a lot, and it does happen from time to time, but it's less common than it used to be, in part because organizations like ACOG and the American Academy of Dermatology and others have begun to sort of foster communication among physicians at all levels to say, what is it that we really should be doing with these
Hmm.
people in this situation? So I think that's actually kind of a positive thing that's come out of this.
Well, Barbara, in this age of, sort of unlimited data and information, do you find that it's better or worse than yesteryear when I was young, and that patients can go online and look up the answer to really any medical question? Therefore, do you find there can be this sense of, well, everybody knows the standard, I found it on Google, and you didn't do that, so you're wrong?
I think that's a risk, but I think there's a way to flip that and look at it in a different perspective.
Hmm.
My daughter happens to have had a fairly obscure cause for repeated miscarriage, which she chased down on the internet and finally found a physician who was willing to listen to her, and she was right. So, sometimes these things have positive effects. So, yeah, I think that physicians particularly get frustrated by the internet docs and the internet experts because patients are rarely able to manage that information well because they don't have the background to put it in. Now, Lorna grew up around a dining room table listening to medicine all the time, so she was a little better at it. But I think it's a sword with two edges. Sometimes it helps. Oftentimes it's very frustrating, and it causes anxiety, and sometimes it causes cases that it shouldn't.
So, in a malpractice or a professional liability case, there's going to be these two parties, and one is going to say, you did something wrong, you didn't follow the standard. What's the process look like for figuring that out? How is it determined if the standard of care was met or not met?
Well, I'm going to paint in very broad strokes because the details vary from state to state.
Hmm.
The procedural details vary from state to state. But basically, somebody goes to a lawyer and says, I think Dr. Jones messed up my case, and here's why.
Hmm.
Dr. Jones, or the attorney Smith, will, if he's smart at all, will ask for the records and take a look at them and have an expert review them and tell him what's going on. Because just because a patient is injured doesn't mean a doctor did something wrong. There are all
Uh,
kinds of reasons that patients can be injured that have nothing to do with malpractice. Second thing he's going to look at is what are the damages. If a patient can be injured, but not badly enough to warrant taking it to court because
hmm.
it's an expensive sort of thing. So he will look at that. And if the attorney thinks that the case actually has merit, that means that there is a legitimate argument that this physician did something wrong. Then they'll go through whatever procedural hoops the state has in terms of filing the case, and then it goes to trial.
Hmm.
Or if it's not settled beforehand. Now, beforehand, both sides will examine each other, do depositions, discovery, look at records, look at history, talk about the case, and sometimes they'll decide to come to a settlement. Sometimes that's because there's a legitimate reason to say, yeah, there was something went wrong here, but maybe we really don't want to go to court and put it in front of a jury, which is, kind of a risky thing. Um, but so some of those will be settled out. Sometimes they'll be settled because the insurance company, the physician's insurance company, feels that it's cheaper to settle
Hmm.
than it is to litigate, because litigating these cases can be very, very expensive. If it's going to cost you $100,000 to litigate the case and 20 to settle it, you settle it.
Sure.
So and
No,
that may have nothing to do with the merits of the
and,
case.
and
Hmm.
Barbara, isn't it true that it's only a small percentage of filed cases actually go to trial?
It certainly has been the case. In talking with some lawyers more recently, it seems like that's shifting a little bit. That insurance companies are becoming a little bit more reluctant to settle, but for them, it's an arithmetic question. You can't blame them. They're in the business of taking care of their clients and still keeping their heads above water economically. So sometimes settling a case is an economic decision, especially if it's a close one.
Now, Barbara, you mentioned the word expert, and so Tom and I would like to think that we're always the expert. Um, but and lawyer land and lawyer world, that has a different meaning. So what is this expert witness? What's their job, and how does one get to be an expert?
Well, an expert witness is basically a witness who has particular expertise in the area of practice that the physician's involved in and can offer an educated opinion on whether the standard of care was or wasn't met.
Hmm.
So that's why a malpractice case gets called the battle of the expert. The plaintiff, the patient has his
Battle of
expert,
experts.
the doctor has his expert, and they go at it. And that's just a function of our adversarial system of justice, is the way it
Hmm.
works. Now, would I do it differently? Maybe, but then I'm not in charge of things. So this is what we have, and this is how it works. And to be an expert, you have to present your credentials to the court, and usually things like you have to be trained in the area that you're talking about. You have to have expertise in it.
Sure.
You have to have a good record as a physician, meaning that you're not disciplined for a lot of things. In addition to that, many attorneys on either side will go after experts who are professionally expert. In
Uh,
other words, who do nothing but be an expert
Ah,
witness for one side or the other. And so that has to do not so much with your qualifications, but your credibility. If you when I started out in law, it was very interesting. I worked as a malpractice defense attorney for some time, and before that, when I was in law school, I had been solicited to be an expert by a number of cases. And the guy who ultimately would become my boss when I went into malpractice defense said, you got to watch it because you're going to end up skewing your testimony to the guy who pays your bills. And so you don't want to get the reputation for only
right.
representing the plaintiff or the defense. And that can be a little bit difficult. Now,
mm,
are there people who do that? Yes. Are they always suspect? No. Some of them are very good and have very good reputations and will give you a straight story. But those are the kinds of things that go into evaluating the testimony, because you think about it, the people on the jury don't know the experts from anybody. And so they have to look at their credentials and their presentation and all of
Sure.
these things and make a decision about how much they're going to believe that person. And
Yeah.
that's the weakness of our system in some ways.
So, Barbara, I think listeners would be shocked to learn that from the time some type of event occurs to the time that a case is settled can be years and years and years. Why does it take so long for the two parties to come to some kind of resolution?
Well, first, it can be years and years and years, but something like 60% get settled or tried within the first 2 years.
Ah,
That's
okay.
not too bad. It's only about, maybe 8 or 10% that go more than 4 or 5 years.
Hmm.
And the answer is usually because it's a complicated case, because there's a lot of work to develop the case that has to go on, because the dockets, that means the court's calendar, are crowded. There are a lot of logistics that go into it. Now,
Hmm.
every physician who's in this situation wants it handled right now, but when you've got 3 or 4 plaintiffs and 5 or 6 experts and 30 witnesses,
Hmm.
and a judge and 2 lawyers, or 3 lawyers or 4 lawyers or 5 lawyers trying to jockey their schedules and make things work, it just necessarily manages to be a time-consuming process. Frustrating to the doctor, but there's no real malice in it. It's just the way the system works.
Hmm.
Now, Barbara, something that I learned after medical school that we have here in Indiana, I think Texas has it and other states have it, and I really think it's wonderful, is that when a case is filed against a doctor, it first goes to a panel of your peers in the state, in your specialty, who you don't know. So, like when I've been sued, or when Chris, a panel of 3 dermatologists or OB/GYN doctors looks it over and then decides. And whatever they decide, if it's 3-0, 2-1, they have declared that they will be an expert for whichever side they think, was in the right. What do you think about systems that do that before they can go to trial?
I think, like anything, it has its upsides and its downsides. Medical malpractice is such an incredibly arcane area that having people who are not experts in the area evaluate the merits of a case is very, very tricky. To
Hmm.
get a guy off the street to understand, for example, the complexities of Mohs surgery is
Right,
just not easy.
but Indiana, it's 3 other dermatologists evaluating
Right.
me
Well, so that is an advantage. Now, the disadvantage comes in: how are those physicians chosen? What are those
by each
physicians?
side. Yeah, each
What
side chooses one, and then those 2 docs
those two
choose the
choose
third.
another? Then that probably works pretty well. It's one of the it has the advantage of sort of sifting out the cases that are going to not do very well.
Hmm.
Right.
The cases that are not meritorious, which, by the way, the the average malpractice attorney who's a plaintiff's attorney has to get pretty good at, because he makes his living by picking cases that will win.
Hmm.
And so he has to be pretty good about that. But in that regard, it's helpful. It does, however, add another step and another time delay into what's going on.
I mean, do you think, based on your experience in both medicine and law, if you had to say at the end of the day, do you think this adversarial system of ours, does it serve up the product of justice to the best of that anyone could do?
Oh, I don't know what the measure for that is, actually. And it's what we've got.
Yeah.
And it's not going to change tremendously. There are a couple of models out there where they're trying to tweak the edges, but basically the civil tort system is the civil tort system. It's not going to change very much. To the extent that we can do things like Tom was describing, adding those kinds of panels up front. In my state, back in the day when I was doing this, that came at the end, sort of as a mandatory arbitration before going to
Oh,
court. So it was the same thing, but a different position, which is why I was a little confused about what you're talking about, because we did it backwards. Um,
Got it.
the system is what it is, and the system is I make a complaint, I make a claim, somebody else has to defend against that claim, and people who are not party to that claim make a decision about who's right on it. That's just the way it is. Now, to the extent that we can filter out the cases that are not meritorious, that we can prevent abuses, and there are abuses, it makes the system better. And there are a number of different ways to do that various states have experimented with, like those panels, like mandatory arbitration, those kinds of things.
Yeah.
Well, this is a great place to take a break about halfway through our interview here on Dr. Doctor. We'll be back after the break with Dr. Barbara Golder and Malpractice.
Welcome back to Dr. Doctor and our doctor lawyer conversation. Barbara, continuing with our discussion, based on your experience in the malpractice or professional liability system, have you seen that it changes physician behavior either maybe for the better or for the worse?
I think it does both. There's a fairly famous case that used to be taught in tort class in law school, probably still is, that had to do not with doctors, as it turns out, but with optometrists and ophthalmologists by extension. But I think it was an optometrist in this case, and it had to do with taking pressures on the eye. And someone developed glaucoma, had been seen by an optometrist and hadn't had his pressures taken. And the question was it the standard of care? Well, in this community, it wasn't. But the court said, this is not invasive. It doesn't hurt anybody. It's important to do this. This is something you ought to be doing. It's a standard of care. Now, that's sort of established by fiat, a standard of care. And that happens from time to time in these cases, particularly if they're high profile or big dollar cases. So I do think that it has a way of driving the standard of care upwards and outwards. In other words, that it makes it not so much a geographic thing as it is, okay, we're in the United States of America, everybody's got access to this particular treatment, you ought to be doing it. So I do think that there are some very positive things about that. I think there are some very negative things as well. I think it's driven up the cost of healthcare because of concern for being sued. If you go into the emergency room with a headache, odds are you're going to get an MRI or a CAT scan, because one of the things they're going to be worried about is, do you have a brain tumor, or do you have a subdural, which are exceedingly rare for people who come into the emergency room with headaches. But if you miss one, it becomes a problem. And you might win the suit, but you're going to spend 3-4 years involved in the suit, and it's still going to cost time and money. So I think it's had positive and negative effects, and it's very difficult to balance the two.
So something that all physicians fear is having their name in something called the National Practitioner Data Bank. What is this horrible pit in the lowest level of purgatory or highest level of hell?
I think it might be in the lowest level of hell, right down there with Satan in the ice, actually.
Along with the traders, huh?
You got to understand a little bit about where the National Practitioner Data Bank came from. It came from the fact that, and this is kind of one of the problems that we have, and I don't know how we solve this one, because my default position is never to make the federal government more involved in anything. Okay, but
yes, subsidiarity.
But here's the problem: if you have every state licensing physicians individually, then if a physician gets into real trouble in Alabama, he can move to Georgia, and Georgia and Alabama may or may not talk, and he can go on and just sort of hopscotch over the country. Now, there were some fairly high profile, very damaging cases that occurred from physicians who did this, and people were rightly outraged. Why should this be allowed to happen? And so the National Practitioner Data Bank emerged as a way of having a national bank of lawsuits and settlements and disciplinary actions and all those sorts of things, so that physicians, when they applied, say, for privileges in a new hospital, they could check and see if there was something in the old hospital. So it's a good idea. Now, I'm not sure that you can demonstrate that, except for the very egregious cases that prompted it in the first place, that it's made much of a positive difference. It has certainly made life more difficult both for institutions and for physicians, just because of the checking and the records and updating and all that kind of stuff that goes on. And there have been some circumstances in which reports were made that were, um, if not wrong, at least not appropriate, not quite right. And there have been some difficulties with physicians getting those corrected, and some damages to their practices or their reputations.
So what goes
So
into this data bank? What kind of information?
malpractice settlements, malpractice verdicts, disciplinary actions, those sorts of things. So things that, and it's a legitimate concern that we have some way of tracking physicians who
Yes.
truly are
Mm.
bad apples. And I think over this, this was in 1985 or 86 that this was established. It's old sort of thing. It's 40 years old. Um, I think it's settled out to where it's functioning as well as it could be expected to, and it's not causing too much trouble, and and when it's used properly, it's preventing some problems. So all in all, I think it's worked out pretty well, but it's not a panacea. It's really
No.
not.
Now, changing gears a little, Barbara, this idea of apologizing. I mean, our mothers told us if you do something wrong, apologize. That's a good thing to do. But if Tom or I, have an outcome that we don't like with a patient, our heart is to go apologize. I'm sorry this happened. But our lawyers would want to kill us for doing that, because they would say, no, no, an apology is an admission of guilt. What are the issues around this, and what are the so-called apology laws? What does that mean?
Well, I think you've summarized it pretty well. An apology is seen, at least in some circumstances, as an admission that I did something wrong.
Mm,
In other words, I was negligent. It was not
mm,
just an accident. It was not just an unfortunate outcome because, life is that way. The apology laws were passed in an effort to sort of remove that fear, because the very human response really is, um, to reach out to the person in front of you who's hurting and do something about it. And in an odd way, maybe not so odd way, telling physicians not to apologize for a bad outcome, which may or may not be a result of the physician's mistake or negligence, has a way of amplifying the injury. When I
mm,
was teaching physicians about malpractice on a regular basis, I used to tell them, look, patients have to be hurt as well as
mm,
injured. They have to feel that somehow you not only did not care for them, but that you do not care about them. Now, obviously, there's a certain segment of the population that's out there to make money on any event, and we're not talking about them. We're talking about ordinary patients. And often, if you listen to patients, they'll say, "I just wanted them to say I'm sorry. I just
right.
wanted them to recognize that they did something wrong." And
Mm,
try to fix it. And I've had experiences with that. I worked with a client who had a very very bad outcome because of a completely indefensible mistake on the part of the hospital. It was just not something that should have happened. And uh, when we went through the process, the hospital just stonewalled the whole way, and it was like, you're just making this worse. If you would just say, you know
um,
what? I'm sorry. What can I do to help? It would be better. And I think that's kind of the message for doctors and particularly hospitals. Doctors are not so much this way, but institutions are, simply because they've got all this accretion of policy and stuff. If something happens, if there's an adverse situation in the hospital, if there's a traumatic event, there are some things that are going to happen. That patient's going to have some psychologic problems because of
mm,
this. It. If a patient, has an ad taking your specialty, you have a patient who has a bad delivery and decelerations and complications, and you got to go in and do an emergency C-section. That's a traumatic experience, and that's going to affect that patient's view of hospitals, and it's going to affect their view of getting pregnant again, and all those things. Makes sense to say, you know what, this happened. It wasn't really anybody's fault. It just sort of happened. But let's get you plugged in to some counselor or support that can help you through
mm,
this. Goes a long way towards, if not eliminating a problem, at least reducing the pain of the person involved. And that's important. So I think if we begin to think of it in terms not so much of this contractual adversarial thing, but in terms, if you will, in Catholic terms, of the relationships and the dignity of people, we can make a big difference.
Barbara, you mentioned Catholic terms, and we are Catholics, and on every show we try to sort of bring that around. But if you're advising physicians or patients, for that matter, from a Catholic perspective, what part of Catholic teaching, if you will, advises us here how to go about these problems?
Well, I think our social justice principles have something to say here. We talked about
Oh,
subsidiarity earlier. You resolve the problem at the lowest possible level that can
oh,
actually address it. So
hmm,
keep that in mind. If there's a way that you can handle it, do it. If you can avoid making things worse, try doing that. If you have just almost killed a patient, probably not a good idea to send a bill to the bill collector. Okay, that's probably not a good idea, but it happens. And sometimes that's what pushes things over the edge. That they were upset but stable until they get the bill collector call, and then
hmm,
they're like, "Are you serious?" So relating to people is what we do as physicians.
hmm,
Certainly, what we do as Catholics. And I think when you begin to focus on the dignity and the needs of the person in front of you and serving that person, you move it in a different sort of direction. It doesn't mean you don't pay attention to the realities of what the law is. You have to. That's a practicality. You can't live in an imaginary world, but you can always do it with the dignity of the person foremost.
hmm.
Barbara, from the patient's perspective, if they feel like they've been wronged, what steps would you recommend they take before they actually pull the plug or pull the trigger to sue a doctor?
Yeah, that's a tough one because it sort of depends on the circumstances, and
Right.
I hate giving general recommendations, because if I say go talk to the doctor, there are some doctors I wouldn't talk to. That's just there just are, and
We're glad you're
sometimes
talking to us.
that can add to the trauma. But I do think that finding a neutral third party to talk it through with is probably a good idea. A pastor, another physician, a friend who can maybe bring a different perspective, because there's always another side to the story, no matter whether you're the plaintiff or the defendant.
Right.
There's always another side to the story, and having someone who can help you understand the other side is very helpful, because then you may see a path to get through this that doesn't require the adversarial system, which depends on not seeing the other side.
Hmm.
So find someone, I think, that can help you with that. Um, Maybe even just making an appointment with a physician that someone recommends and say, I just want you to talk to me about this, and tell me what you think about this. I'm not going to ask you to be an expert. I'm just trying to find some solution or some answers here. Now, whether or not physicians are willing to do that depends a lot on the physician. Many times they don't want to, because it's often a colleague that they're talking about. But um, that's one approach. Sometimes institutions will have an ombudsman,
Sure.
a patient representative who can help fill that role. So that's another alternative. And there are now physicians who sort of do the second opinion thing, because that's their whole um, purpose in life, to sort of say, let me look at this. There are not many of them, but there are some out there.
Hmm.
So that's another way to do it. But to find a way to see the other side before you have to go into court to see the other side, I think, is always a good idea.
Yeah, because what in Matthew 5 doesn't it say, come to good terms with your accuser quickly while you are with him on the way to court? So you don't end up in prison. That sounds like that principle right there.
It does. Well, I mean, it does, and everything about our legal system tries to make that not happen.
Hmm.
Our system is punitive, it's adversarial, and it's not meant to do anything except settle things so that they go away. I mean, it's supposed to help with making patients whole and all that, and it does to a certain extent, but it's not meant to meet their emotional needs, and those emotional needs are really important.
Hmm.
So,
Yeah.
Barbara, if
Well,
I'm a medical student or a doctor and I'm not really good at apologizing and I know I need to be better, what are some tips you can give listeners who might be in healthcare professions or to me about what are good ways to apologize?
Well, I think sometimes a good apology just starts by listening to the person who's been hurt. You know, what tell me what you experienced so that I can know where you are, because I want to respond to your needs.
Hmm.
You know, and sometimes that's very different than what you think it is. You may think it's I nicked the bladder, but what it really is you didn't listen to me when I told you I was hurting after the surgery and I needed more pain meds.
Sure.
So start by listening to the patient, and again, our medical systems are driving us away from this. Physicians are so pushed to record things and ask standard questions and fill in
Yes.
blanks and do all that stuff, that sit down and just listen to the patient is really not at a premium anymore.
Mm.
So start there. And if you're going to apologize, you might as well know what you're apologizing for, right?
Amen.
So
That seems like good advice. It seems like the stuff that our mother told us when we were younger. It's usually moms are right, and this sounds like another one of those cases. Now,
I think that's true, but the caveat there, because there is the lawyer in me, is don't do that unless you've had a discussion with your malpractice company about what their process is, because they may have very different opinions on this, and you're sort of obliged to follow their lead on these things. So don't go off rogue here. Have some communication, and good malpractice companies are now recognizing that it's in their benefit to do this too. So they may actually have a course for you. You never know. Ask, and if not, tell them you want one.
yeah, it's interesting. A mentor that I really respected in medical school said to me once, if you do the wrong thing, you may be sued. If you do the right thing, you may be sued. So just do the right thing. But I mean, for medical listeners, I think there's probably some wisdom there in his advice. And then the other thing that strikes me is what you're really describing in the ideal interaction is genuine empathy. And it would seem that the healthcare providers who have that trait and that virtue are rarely the ones that find themselves on the other side of professional liability cases. No, that's not always true. But often they don't get into the trouble because of that genuine empathy.
That's right. And in some ways, it's very random. At least it seems to me. I mean, there are states where 3 out of 4 doctors have been sued. There are states where 1 in 10 doctors has been sued. I don't think there's that much difference in how doctors practice medicine in those 2 states. A lot of it has to do with the culture, the environment, the legal system, and all that sort of stuff. So
Sure.
there's a lot that's out of your control. But what's within your control is the ability to be a physician that a patient trusts and forgives, and will come to you before things have gotten to be so bad that there is no result except a malpractice suit.
Barbara, in our last 30 seconds, what final advice and wisdom do you have for our listeners?
Just do the right thing. He's right. Just do the right thing. It's much easier.
It is.
I'll toss you a question you weren't expecting then, because you answered that one too quickly. I happen to know that you're a big reader. What is your favorite lawyerly novel?
Ooh, lawyerly novel. I haven't read too many lawyer. Actually, it's probably Rumpole of the Bailey.
I'm not familiar.
Yeah, it's a series of little mystery, sort of mystery legal stories. Rumpole of the Bailey, and I can't remember the English actor who did it on BBC, but there was a series. It was delightful. Look it up; you'll enjoy it.
Excellent, thank you,
Barbara. Thanks for being with us for another episode of Doctor Doctor. I'm probably not going too far off basing. We'll probably have you back again. God bless you.
I look forward to it. Thanks.
Well, welcome back to Doctor Doctor, and welcome to the answer to this episode's trivia question, category physician responsibility to patients. And Tom, you reached way back in time for this one.
Way back in time, where if we cause someone to die or to lose an eye as a doctor,
we just cut their hand off.
We just cut their hands off. Was this document written in England, Iran, Italy, China, or Greece? The answer is Iran, the ancient Babylonian Empire. In 2030 BC, over 4,000 years ago. And for those of you keeping score at home, this was on the Code of Hammurabi.
Wow. That's an intense penalty for making a mistake, isn't it?
Yeah, I don't think I'd want to be a doctor. I mean, they didn't even know about, infections and oh my goodness. I just can't imagine taking some little sharp piece of metal, sticking it into somebody. No, that's dangerous living. So we probably have come a little farther along in today's malpractice system.
Let's
So,
hope so.
Chris, you probably have the top 3 takeaways for this episode.
Well, shockingly, yes, I do. And the first one, let the record show, as lawyers like to say, I'm taking the attorney's side in my number one top 3 takeaway. And when I say that, I mean, it's a lot of fun sometimes to bash lawyers. I actually have some really good friends that are lawyers, and some of them have actually sued physicians that probably needed to be sued. But this idea that behind every lawsuit, there's a patient, there is a person who, whether they've been hurt or not, they feel like they've been hurt. And they deserve our respect. So don't take it out on the lawyers. They're not necessarily to blame. Number
Very
2,
good.
damage doesn't equal malpractice, right? Barbara pointed out very nicely, you have to be hurt and injured. And so this idea that just because a complication occurred, that doesn't mean that you didn't follow the standard of care or that you damaged someone. And that's an important principle. And then that really leads, I think, to the last one, and that is communication. It is so important to communicate. As we pointed out early on, so many professional liability cases really boil down to poor communication. And, I would say to listeners that are patients, you have some responsibility to make you understand. And in that relationship is not a time to be polite and to be reserved. If you go see Dr. McGovern and he tells you he's going to cut the end of your nose off, he's got to make you understand what that means. And if you don't understand, stop him and say, I don't understand, and I need you to make me understand. So those are the top 3, I think, at this point, as we think about our legal colleagues.
I think you did that quite well, Chris. And so I will thank our listeners for being with us for another episode of Dr. Doctor, the award-winning radio program and podcast. Please share the good news of Dr. Doctor with a friend. Invite them to listen on their favorite podcast app.
And please look up this and all of our episodes on our website, drdoctor.org. And if you want to dive a little deeper into some of the topics, we've got notes and bonus information linked to each episode.
This is Dr. Tom McGovern.
And this is Dr. Chris Stroud. We're signing off until your next dose of Dr. Doctor.